Is healthcare a human right? That's today's big question. It shouldn't be a question, but my guest today is Dr. Sheila Davis, and she is the CEO of Partners in Health. We need 500,000 more nurses here in the U.S. alone, and millions of them, and community health workers the world over. And that's where Partners in Health and the tens of thousands of community health workers and teachers and hospitals and training centers they've built around the world in 11 countries, that's where they really come in. And I'm so excited to share their story and their model with you today. Dr. Sheila Davis, thank you for joining the show. I'm hoping we get to the end of this. That's my goal for literally this entire week, is that we get this thing done. I'm so thankful and appreciative and cognizant of how important your time is. So I like to start with one question. Why are you vital to the survival of the species? And I encourage you to be bold and honest.
I think I'm vital to the survival of the species because I firmly believe we can be a better species than we are now, and that we're all critical to our survival is so interconnected. And what I'm doing is making sure that people around the world also have the same ability to survive in a way that allows them to live a full life.
That sounds pretty reasonable to me. I think I mentioned to you, I would like to start with talking about Paul a little bit for folks who aren't familiar sort of with him and how it started. But one of my biggest takeaways has always been that's his ethos, which is, all lives really should be valued equally. Everyone deserves care, some level of care, at least. So I have a few notes here, just so I don't forget anything. And please just stop me and correct me wherever I'm wrong here. Just starting with Paul Farmer, sort of the father of redistributed justice. And I always think of that idea of that moment of him stealing the microscope from Harvard to take to Haiti. And so in 1985, I believe, co-founded Partners in Health, which, again, it's right there in the name, and we'll come back to that. But you all are legendary now among the public health community, started in Conj, decades of incredible, tireless work there and around the world, seeking health justice. Paul died in February, I believe, 2022 at such an early age. So I wonder if you could get us up to speed a little bit, because Partners in Health has changed and grown so much. So how many folks would you say the organization serves now?
So we serve in direct care, meaning that we touch the person, about 8 million people a year.
Wow.
I think in terms of who we are hopefully influencing, the amount of care that they're getting around the world is over 40 million, many, many million, because of the work we do in changing global policy on treatment for HIV, MDR, TB, and now with oncology, mental health. So I think our direct touching is 8 million, but the impact is far greater than that.
And that is such a important, nuanced point, and I want to dig into that. And I actually have a sort of a semi-personal story about that. But that's also, I imagine, a struggle to be able to do both things at once. So how many folks you're in? Is it 11 countries now? 12 countries, again, directly?
We're in 11 countries, and we have about 19,000 employees around the world. The vast majority, about 12,000, are community health workers.
That's incredible. That's so amazing. So I want to ask now, now it's May, which is incredible, 2023. I'm not sure exactly how that happened. It's been almost a year and a half for you all since Paul's unexpected death. How is the organization, you folks who knew him best, and all of these other tens of thousands of folks who are trying to emulate his work and learn from his work and your work, how is everyone healing? Because you are still a small organization, really.
Mm-hmm. Yeah, I think the personal loss will continue for a lifetime for many of us who he was a part of our daily life. And I think, his family's here in Miami. So me being able to be close to his wife, Dee Dee, and children and brother has been great. But it's a huge loss. I think was our North Star. He's the one who continued to, I think, just really put a mirror up to the world and say, like, this is just crazy that there's stupid deaths that happen in the world. And he could say things that other people could never say. And he really believed that it's a big tent. Everybody should be in the tent, and would talk to people who you would think would be on the other side of our political agenda. So he was a once in a lifetime human being, or once in a generation. I think, the beauty of Paul, though, is that he didn't ever think that it was one person who could do this. And so part of the ethos of PIH is that we've trained people from day one in every place that we are and we work. So even from a small clinic in Conj in Haiti, part of it's delivering care, but also making sure others are learning how to deliver the care. So in all the countries we work, the care is delivered by people from those countries. We don't fly in and drop people from the U.S. there. Our care is delivered by people in those countries. And our leaders are all from those countries too, and have all knew Paul, and we're able to, I think we're able to see what his impact has been. We have a strong strategic plan that he worked on, and he imprinted all of us. I think none of us embody Paul solely, but we all have a piece of him in us. And it's fascinating, who takes on what role when we're together as a leadership team, because he was also the disruptor. He was also the cheerleader. He was the visionary. And there's not one person who's doing that now. There's a group of us who are doing it, which is also, I think, the beauty of Paul. And I think he would be pleased to see that.
Well, that's beautiful. Thank you for sharing. And I'm so terribly sorry for your loss and how abrupt that was for his family and you all who are obviously part of his family, and so many folks who he helped. It seemed like he was almost dragged into it and then tried to really show how your organization and the work in Conj and then in Haiti and specifically could be a model, at least some base elements of it for so many other places to train other people.
Yes.
I've been reading Paul's work and reading, starting with Mountains Beyond Mountains, like everyone, for so long. But this was a person whose focus and intensity and very direct way of doing things, whatever it was he was doing, it was so difficult to replicate that he was very much pulled in truly 1,000 different directions over time. And, I think that applies to any job or role, whether you're a parent or one part of a band or whatever it might be. But I always tell this story, and it's so funny. I thought about it because it relates directly to PIH. So my sister, who hopefully doesn't kill me for sharing this story yet again, actually interned with PIH years ago, 2014. And she is the best of my siblings, and I, like by a long shot. It's not even like a close horse race in this regard. We've come to terms with a long time ago. But she went to Tanzania and built a school with her bare hands. She also has been a teacher for children with learning disabilities and low-income children. And she's also run volunteering for both of the Obama campaigns and struggled always with this sense of, do I want to affect 8 kids today for sure and change their lives? No questions asked. Or do I want to work in policy and maybe affect millions of lives in a slightly more vague way? Mm-hmm. And it's really difficult to do both. And it's really difficult to find an opportunity to do both. And I've always kind of thought about that through my work and everything, but it's so specific to you all. So I'm curious now, with tens of thousands of community health workers and after Paul, how are you all doing the hands-on work, continuing to do the hands-on work, and definitely affecting a few lives directly, and simultaneously the policy work? Because as many people as you all touch now directly, there's millions that could use the care that you all provide. Thank you for letting me go on about that.
Yeah, no, it's such a good question, because I think we also have this conversation of who are we? And with Paul, we would have this conversation, and because the need is endless in terms of direct care. We could raise billions and we still wouldn't fill that need. And so I think the decision was made a long time ago to really look at like a theory of change. So, you can just provide care, super important, a very important thing that people do that. And to do that solely will impact that community. But I think the goal of Partners in Health is we create models that then can be replicated, because we don't want to be in 100 countries. I can tell you, I get an email every week saying, can you go to this country? Can you go to this country? And that is not who PIH is. Our goal is to do the direct care so we know what we're doing, and we'll always do that. That's our credibility. That's our heart. But then also, how are we then training and educating along the way? Because we need that generation behind us to be doing this. Then how are we influencing with evidence? How are we starting people in Haiti on HIV treatment, and how we're able to then, change the global policy of changing the drug prices for antiretrovirals to challenging the world to say people have the right to have life-saving HIV treatment. And then how are we influencing that to make great change? And then how are we replicating that? We opened a university 5 years ago in Rwanda, the University of Global Health Equity. And the goal of that is, how are we taking all these lessons, educating a whole new generation of healthcare providers and those who work in healthcare delivery in a really different health equity lens? And how are we going to change the world? Because we, made the decision a long time ago, even though it's a hard decision every day of, do I hire a midwife, or are we hiring a policy person to be working with the ministry in Sierra Leone? But then by the work we're doing in Sierra Leone with the ministry, they're able to get money from the World Bank they couldn't have gotten, and they're able to roll out the PIH model of care to the rest of the district. So I think it works in this crazy way, and one only works because of the other part of the puzzle. We would have no credibility in public policy if we didn't do direct care. And we can do direct care constantly, but we're not able to really push that systemic change if we're not working at the national and global level.
Thank you. I mean, that seems like an easy answer for you to be able to put forth, but that's decades of struggle to get to that point. I imagine, and I imagine it's still, this, I feel like the question I answered most for folks, or the best advice I could give folks at the beginning of COVID, when the best answer to what can I do was nothing, is control what you can control. And you all identifying the fact that we shouldn't raise billions of dollars. We should not be in every country, because we would have to sacrifice one of those two tent poles. And if you sacrifice one, the other one becomes weaker. It's got to still be a struggle. So you've got the university now, and you're in, again, 11 countries, and training all of these community health workers who train each other. Sort of formally, structurally, what does a pipeline look like for someone who wants to train to be a community health worker in one of those countries? Is there a version where they graduate to the broader community level wide administrative or management, to statewide to countrywide, or are those really two different sort of paths?
I think it's a really good question. I think both. I think that, the vast majority of people from those communities who will stay in those communities, and we certainly have people who become supervisors, community health worker supervisor, and may move up to train to be a nurse's aide, or may go to nursing school, that type of thing. But I think, by far people stay in the community part of their role. And I think that there are always opportunities for people to kind of grow, but we don't have an endless, limitless supply of jobs. So I think part of it is also training people so they can get a job other places as well. And so we're not, we think it's a success when people move to a different place and get a job, because even when that's people in the US, we just found out that one of our long-term people is leaving. And, immediately your thought is, oh no, how's it going to impact us? Yeah. But then it's this is a win, because she's going to bring 11 years of great experience to a different place that doesn't really run like Partners in Health, and be able to infuse that in a way that is going to just further our mission, and so we see it as a win. But I think community health workers do have moved to work in the depot. We actually, in Sierra Leone, on our construction team to build this fraternal center of excellence, we have women construction workers for the first time. And they're the brave, paving the way. And it's a first in Sierra Leone in this area. It's now our major welders are all women, because she's gotten her friends and built this cadre. It's awesome. It's this amazing thing that you see, that who would have anticipated that's going to change the life of so many people by little girls seeing that there's women and little boys saying that there's women doing these jobs. Like that in itself is such an amazing transformation.
I love that, which is like, it depends, basically. It does. We are open to it. It obviously, if someone leaves and moves on to something else, that might, we might have to scramble a little bit or think, how do we fill that hole? But in the end, the overall win is hopefully we can spread this a little further. My wife and I were very lucky recently, longer story, to spend some time at the Mayo Clinic. And we have some wonderful medical folks and health folks in our life of a huge variety. But, you go there and you're like, well, this is Star Trek. Like, nothing is perfect, but what on earth is happening here? And truly, from the way the buildings are structured to the way the institution and the patient flow is structured, it's very difficult to walk away and not go, wow. One, how do we do this other places? But if you're at all familiar with at least the healthcare structure in the United States, at least, to go like, oh, well, you really probably can't pivot what we've already got. It's going to require like starting some things new, because a couple people leaving from Mayo Clinic or a couple people leaving from Partners in Health, like it's very difficult to really have an influence on these big, big institutions that are already there that have all these incentives in 1,000 different ways.
Right.
So if I'm someone who grows up in the organization and does well and then thinks about, you know what, I think I can actually really go have an impact here. What's the best way for them to do that? How do they go? Because your situation is so unique and hard to capture.
I think part of our goal is always that we're seeking opportunities for people to grow professionally, educationally. So, we have started these residency programs in Haiti, for example, and that's training. The first emergency room residency program are people all trained at our University Hospital in Mirabelais. And that's an opportunity for people to become a specialist that they didn't have in Haiti. Training nurses to become nurse anesthetists, like another pathway for people to learn. Some people get an opportunity to travel and study at a university in Norway or in the US for, master's programs. And then they come back and they're able to kind of share their information. I think why we have started the university, though, is we know that those opportunities are not, everybody doesn't have access to a Fulbright scholarship, for example. And there's so many amazing people. So how are we also giving our amazing doctors and nurses who work in Lesotho to be part of this university in Rwanda and bring their lessons learned? Now there's going to be students from Lesotho who go to study in Rwanda for the first time, to be exposed to a really, really, really different world. So I think the goal is that we're trying to always cross-pollinate everybody and each other and see where there's partnerships, and Partners in Health means we partner with everybody, with other great organizations, partners with ministries of health around the world. And so part of it is are there opportunities within the government for people, or do we need to provide our government, colleagues an opportunity to go to a conference and learn and train? So I think it's this big kind of ecosystem that we're trying to continue to build. And it varies greatly in where we can get visas for people. Sure. We were all supposed to just meet in Peru and found out that we couldn't get visas for some of our executive directors who were based in Africa for for racist reasons, basically. Yeah. And so it's also confronting and battling those structural violence that is embedded in our culture and our society too, and trying to see what can we do to change that and address that. And where do we have to say we have to move the meeting, because we're not going to have it in Peru without half our people.
And that's always the hard one, right? Is going like, So my wife is the greatest human alive and a hardest worker and talented and successful and all these wonderful things. And she's a screenwriter and producer who are on strike as of 8 hours ago.
Yes, I saw that, heard that.
Hollywood, it's a nightmare.
Yeah.
But part of the reason people work with her so much is because she's so good at what she does. She works so hard. The second part is she's the most wonderful human. But the third part is that part you just talked about, which is going like, hey guys, we have to move the meeting, where she can be very, can take her writing personally and care about the words on the page and care about how an actor's feelings are or this budget or this. But the end goal is always, we're trying to make a movie. And in the end, same thing, this is why I come back to Mariana Mazzucato's book, The Mission-Based Economy, about these clear, measurable outcomes. Like if the goal is to put someone on the moon, everything you do up to that point has to answer to that. all your processes and your teams. And if the goal is like, we have to have this meeting or we have to get this movie made, some things are going to be sacrificed along the way. And that doesn't make it better or worse, but it has to be measured against like, can we have this meeting, which I'm sure there's some intended outcome out of that or process out of that, right? I want to talk about that because as much as we've talked about sort of pipelines, and I want to talk a little bit about how you actually recruit folks to be community health workers in these countries, or in the U.S. Your path, you went from some doing the on the ground work to running an organization like this. And just for a moment, again, from my notes, and please correct me everywhere I'm wrong. I'm used to it. It's my day. I have children. Chief of Clinical Operations and Chief Nursing Officer at PIH. You oversaw the nursing and the supply chain and everything. Chief of Ebola response for PIH in 2014, 2016. You were co-founder of a small NGO before that that was in South Africa and Boston. You worked on HIV and AIDS. How important do you feel like now, especially now that Paul has left us, and everyone's trying to both fill his shoes, but in a different way? How important is it for someone to run an organization like yours, to have so much on the ground experience? And where do you feel like a few years in that it's an obstacle in some way?
Yeah, I think I was an uncommon or unexpected choice for this role because I'm not a Harvard trained physician. I, am somebody who was definitely from the ground up, working at PIH for about 10 years before I became CEO and didn't want the job. I was asked to interview with the search firm because they were trying to see, get ideas. And at the end of this kind of interview of just, getting ideas, the woman said, I think you should put your hat in the ring. And I thought, there's no way in hell they're going to choose a nurse, you know what I mean? But I thought this is a chance to get my ideas on the table that are not just my ideas. They're ideas of having worked in every country we are working, spending long nights, up late, long travels where you really get to know people and these amazing people around the world. So these weren't my ideas as much as the synergy of all of them together. So I just was super painfully honest. And my word of advice always, if you don't want something, then you're always at your best because you're going to be authentically yourself. So I was really authentically saying, I think this is where we need to change. This is what we need to do. And I think because I had worked in all of the country sites or most of them and knew people, I could speak authentically to really where I think we need to be pushing decision making to those in closer proximity, where, I thought that we could shift the way that our leadership structure which was US focused, and was able to, I think, speak honestly about how I think that was important. And then had built up political capital through the years so that when I did take over the role 4 years ago, I made some pretty drastic changes, but had some political capital because people hopefully knew that I was not somebody from the outside. They trusted that I kept the patient at the center. So I think that allowed me, I think, to really do things a little differently than had I come in from the outside. I do think though I miss the interaction with patients. I even miss the interaction even with the frontline staff in a way that my job doesn't, I fly in and fly out, which I always used to hate when people did that. And now I'm that person who flies in and flies out, which is like my own issue. So that was a personal loss of, wow. And how do I make sure I don't lose what I think makes me a good leader the further I get away from it? And I think all leaders struggle with that. And I think about that probably more so than I should of worrying about that because I do think it's, so many errors are made in life and in organizations when there's people who don't have good proximity to what you're trying to do, make all the decisions. So that's why I restructured the leadership team, did all this to put systems in place to help counteract that. But there's a personal loss of feeling like I don't have the same connection with people in the same way of patients.
Could you possibly make bandwidth, make time to do that in some way? Is there some, I think of, Google, for what it's worth now, had forever their sort of 5% time or 10% time for people to work on side projects. And we've talked a little bit here about this idea of like helping other organizations, not like a PIH, empower their workers to use 20% of their time for something that is future positive in some way, whether it's related or not. Is there room for you to spend some time with patients at all? Like, does that exist? Do you feel like it would, I don't want to say check that box, but do you feel like it would fulfill what you feel like you're missing?
I think when I first started at PIH, I did keep my practice at Mass General, and was able to kind of combine worlds. And then when Ebola happened, and I was in West Africa most of the time, and when I wasn't in West Africa, I couldn't get into a hospital here if I wanted to because of the Ebola scare. Yeah. So that kind of had to abruptly stop me taking care of patients. And now that I'm further away from it, I'm probably not the best one to do it anymore because I'm not up to date on the same HIV medications in the same way. Sure. I think when I do go do visits or, visit sites, I try to spend some time in the hospital just to, connect with the staff and say hello and say, talk to patients. But I feel like there's, at this point with what my role is, that would be self-serving for me, but not necessarily benefit the whole. So I think that's, I try to get snippets of it, but I think it's hard to incorporate that. But I do think in a lot of instances, I hope more and more companies do that. And I think most of our clinicians who are US based all have their clinical practice that they've kept, even though it takes a lot of maneuvering to get time to be doing the big chunks of time. Sure. But I think that's what makes them still effective. So I try to infuse it in others.
It's funny. My children now are, they think they're 20, but they're 10 and 8 and 7 or whatever. They're all convinced they could, live in an apartment and have a job by themselves. But it's this thing, right, where you talked about the fly in and fly out. And now you're that person, and how I try my best to be a father that's there, to be a father that is, I'm very privileged to be able to be there as much as I want to be. And that they're healthy in these things. But, those moments where you can, I'm sure you had this with your kid who seems to be an actual adult now, those moments where you find yourself saying to some small child, like, because I said so. And then you're like, oh my God, like, how am I, now I'm that person. Everything I did was to not be this,
So true.
How do you wrestle with that? Do you feel like those are some of those decisions you made, those radical decisions and new systems you put in place to make sure that like it's okay for me to be the fly in, fly out because we're actually more in touch in better places?
Yeah, exactly. I think, by dismantling the executive leadership team in Boston, like day 10 or something, and creating a leadership council. So our 11 site leaders are our leadership team. And so that's who is helping making the strategic decisions about budget, about growth. And it's hard because they also are running their own countries. But I think it's been, built in the system and the structure so that it's not a sole decision maker. Yeah. And I think that's where, as I've gotten older, I appreciate systems and structures more in a way than I did before when I was kind of an anti-structure person. Sure. Because that is building in the systems that when I'm gone, that exists. Somebody could come in and change it, but hopefully they couldn't by the time we've morphed this to really be an organization that has leadership that is not just in the US. But the person who takes my job someday shouldn't be sitting in the US. Yeah. We're a global organization, and I'm hoping that we're infusing enough of those systems in place so that we've changed the kind of the way that PIH operates.
Again, part of my job, and I'm like a dumb liberal arts major, to be very clear, like generalist is a gentle use of the term. Like flashcards were never my thing. I learned I can ask good questions. That's it. There was you didn't want this guy's a doctor or scientist or any of those things. But those constraints, as we'll call them, were very illustrative to me once I threw my ego aside, which is it makes you ask this question of, well, what can I do? And I always love that formulation, those 4 words, because it's the one we hear the most, and we base all of our work on, whatever it is, whether it's COVID or health or climate. Because you can say it so many different days. You can say, what can I do? You can say, what can I do? You can say, what can I do? And those are all actually really different questions. And there's been 1,000 different systems. What do the kids call them on Twitter these days? Constructs, I don't know, to frame that. And the best one is usually like, what are you into? What are you good at? And the intersection of those two things, I can point you to 70 different measurable, reputable places like PAH where you could be put to use, whether in a donation role, volunteer role, full-time role, whatever it might be, a lateral move. It's very easy to answer that. And for myself, I started when one of my dear cousins got cancer, and I didn't know, this is 15 years ago. And I was like, well, what can I do? What can I do? I was like, oh, I can't literally directly help her because I'm a moron. But I was a college athlete, which this was a long time ago, I can sweat. And so I found Team in Training, which is the fundraising arm of the Leukemia and Lymphoma Society. And they've been around for forever. And I was like, this is amazing. I can do this. I can give the money to the smart people who know what to do with it. And that's fantastic. The point is, we have to throw the kitchen sink at so many of the things we're doing these days, which is a problem and an opportunity. And it's wonderful. It's proven. We did it with smoking, from the courts to marketing to regulations, whatever it might be. We, have done it in some ways with COVID, and we're working on it with climate and clean energy and food. How do you talk to young folks who are trying to get into public health, whether you're directing them towards PIH or not? And we can talk specifically about how you recruit or entertain, new classes of community health workers in these countries. But how do you talk to those folks about how they can get into this sort of thing, knowing what you knew about really the people who need help the most and aren't getting it?
I think so much of this is a lived philosophy in a way. And I was just talking to a group of nursing students the other day who all, from the US, who wanted to I want to do global health. And I always say global health is in Miami, it's in Boston, it's New York. To me, it's the lens in which we care, which is focused on equity. And is basically saying, if you're living under a bridge in Miami, you deserve the same treatment for your breast cancer than if you live, at the Fontainebleau kind of thing. And so that getting involved with social justice issues in your own backyard is literally the PIH's mission. Yeah. Even if it has nothing to do with PIH, because it really is. This has to take a transformational shift of our society. And it's really seeing, not in a charity way, but more of this is a moral responsibility that we care for each other. You can do that if you're an athlete and you can raise money this way. If you're a scientist and can do something, if you're a travel agent and can help get good flights, there's the way that you can contribute. Paul used to talk about something called expert mercy, and expert mercy was what, we need expertise in so many different ways, and it's what you bring to it from what your gifts are or your skills are. So if I'm a teacher, expert mercy is I'm making sure that kid in the classroom who's from Haiti is proud of where they come from. Because when we talk about geography, we talk about how Haiti is an amazing place. Sure. Not just the horrible things you hear in the news. Sure. Or as a nurse, it's spending time with somebody. So I think it truly is this getting engaged with these justice issues, whether it's about, incarceration or whatever, because it is all about seeing humans as equal and deserving of care and dignity. So I think that is where there's so many, in every place we live, there's so many places where people need help. And I think seeking out organizations where you work and actually being that help, and whether it's driving meals or doing this or doing that, and being okay with that and leaving your ego at the door to do that, I think is a big piece of it. I think obviously raising money, for organizations like PIH is critical. We can't do what we do if we don't have the resources to do that. We also do a lot with advocacy, and I think this is whether PIH is your thing, and our big issue is global health funding, and or it's gun control or whatever. Really taking the responsibility to not just turn off the news when we all want to do that, but to get actively engaged, even if it's hard. I think is an important thing. The Paul Farmer Memorial Resolution was launched. It was put on the congressional floor last year, and it really is trying to change the way global funding happens. Right now the U.S. gives about $12 billion a year. We think the U.S. should be giving about $125 billion a year, and it's still a minute amount of money.
Oh my gosh, that's nothing compared to the whole budget.
It's nothing. Yeah. It's nothing. And so advocating and learning about that process, to call your congressman or doing that, seems like it's not a lot, but it's when those little pieces all come together, it is a lot. So I think all those things are ways that people can remain engaged, and also ways that we can hopefully get people to also look beyond your own backyard, and pay attention to what's happening in Haiti now, pay attention to what's happening in other parts of the world. That I think opens your mind up, open your kids' minds up, and that I really think is going to take this major effort to change our society. And I think those are ways that can happen.
I love that. Thank you for sharing that. One of my biggest takeaways from all Paul's work and his published work and work published about him over the years, and all of your work doing this model and then trying to prove this model in other places, both the work, but also what you've gathered from the work, the TB treatments and things like that, is this idea of, and it, I feel like we can apply this to so many different problems, which means it's probably too simple, but that's the point, is it's this idea of it doesn't have to be this way. It's just a series of decisions that people made over time.
Yes.
But also, why is it this way? And this is where I use, again, something I've taken from my children, which is this just relentless barrage of why to get to the bottom of this problem. Because then we can start from the bottom and go, these are the immovable pieces of the things everybody need, which I believe you said in your statement about Paul, and he's always talked about, again, everyone having equal opportunity, this idea of the power of accompaniment. How do you build that into the culture so that it is transferable among all these different countries? Because especially in the U.S., someplace that's the richest country in the history of the world, per capita spread it around, we've really lost that in a lot of ways, because most of these medical
100%.
institutions do not operate in that way, no matter how much money you've got. If the base element is we don't have community health because we're not spending enough time with one another, we don't know each other well enough. If that is, and those are the base elements we need, how do you build that and institutionalize that and then hire people to do that?
Yeah, I think COVID was eye-opening. I think many of us knew that the U.S. health system was really inept in a lot of ways. Mm-hmm. And I think COVID illuminated that. Like we build phenomenal hospitals. If you need the highest tech gene therapy, this is the place to be. If you're a young, struggling mother who lives in a community that's, one zip code or 2 T-stops away, our health system doesn't serve you at all, because all of our care, our reimbursement systems are all based in hospitals. Mm-hmm. And that's the most expensive care with the most expensive providers. We're so skewed. So when COVID happened, and all of a sudden it was like, wow, we don't have basic public health departments because they've been defunded for decades, right? Yeah. And insurance companies don't pay for that. And we see that healthcare is a commodity, not a right in this country. So that's where it's been built. So it was eye-opening for people to say, why the hell is PIH being involved in the US? Yeah. What can you, who works in Haiti and Sierra Leone, help us in Chicago, right? And I think it was an interesting moment to see that. It really showed that, we had a lot of value add, because our whole ethos is grounded in the community. We have 300 hospitals around the world. We do hospitals too, but our care is grounded in the community. And we know that you need trusted messengers. So when it came to starting vaccine efforts in Chicago, for example, and there was not uptake in certain communities, we knew why, because it's the same thing that happens around the world. We don't have people in the community. So we work to build trusted messengers and ambassadors around vaccines. None of it's rocket science. Part of it is, are you providing food for people who you're asking to quarantine? Stuff that we do innately as part of the PIH model was kind of earth shaking for the U.S. healthcare system, which is so surprising. So we've stayed in 7 communities in the U.S., and some of those communities are building community health workers into their systems. And I think, our goal we're going slowly, seeing where we can be of added value. We're not providing direct healthcare here like we do around the world, but we're working with different entities, systems, health departments to try to look at the community health worker model. And it's happening in some places in the U.S. really successfully. How are we making sure that becomes part of the care that happens, and how are we pushing care into the community? And there's such a huge need, and it's much cheaper to do it that way, right, and high quality to do it that way.
And it's preventative based, and it's all of these things, because, I always came back to this idea. And again, you thought about during COVID, when the most instructive thing you could tell people is like, stay home, don't do anything. What you lose is that power of accompaniment. You lose this connectedness and this trust, because I imagine coming back to working in a place like the U.S. And I know, again, like you have a bunch of folks who still share practices back and forth. And, I know Paul did the same thing, but there's a fine line between saying, hey, these practices, these base practices, we have proven in 11 different countries, and we use in our teaching, in our hospitals, and in our community health clinics. But then going to a new place, because like you said, the messenger is just as important as the message.
Yeah.
Going to them and saying, let me ask some questions about how this might work in your specific culture, whether that's Chicago or Uganda.
Mm-hmm.
One of my earliest conversations, please don't listen to it because Lord knows I was terrible at it at the time, was with this incredible nurse, Karen Huster. And she talked about her experience in the Congo with Ebola, and how important it was for the messengers, because so much of the folks who were not interested in care were because of religious beliefs or whatever it might have been.
Yeah.
And it's not super helpful from some white guy from the UN or wherever to fly in and be like, you need this vaccine. Totally. It's not happening.
Totally.
So how do you bridge that gap? How do you constantly go to new places and say, look, this works, but also like, let me have some modesty about this because I don't know your situation as well.
Yeah. And we only go where we're invited. I think part of it is, because we know that there has to be, it has to be catered to where we are. And that's why the US, I think, is a great example of, we were at 19 different places during COVID. What was happening in each 19 place looked totally different because it depended on what was needed. So I think we always come in with humility to say, we don't have all the answers. I've never delivered care in Chicago. I can't tell you what it's like. But this is some things that have worked in other places. And how could this work here? Or what do you need? When we first started working in Newark, for example, they needed basic things like money for phone cards for the initial people to doing outreach. Or we pay for electricity in some places and other places of the world. Like, we don't say we're healthcare providers, we're going to do this. We say, what do you need to take care of your people in your community? And then accompany them and do what they know the answers are, but often don't have the tools to do it. Whether it's analysis, it's monitoring the evaluation, it's statistics, whatever. It's creating community health workers in Immokalee, Florida. But it's always based on champions on the ground who have the same kind of ethos of people are people, and we need to treat them the same. And like finds like, you know what I mean? Which is the beautiful part. And then it's saying, not this is the PH model, because the PH model looks different every place we work. There's some core components of it, and it's more like we're pragmatic solidarity. So we'll stand in solidarity with you, not just hold a sign, but like if you want to create a vaccine ambassador, like this is what we think we can do, whether it's money, expertise, or whatever, but you know better than we do. So we're here to be with you and accompany you and not lead you. And I think that's why we continue to iterate. What happens in Chicago is influencing now what we do in Liberia. Like, it's all a huge, no one place has all the answers.
It seems like if anything is most transferable, and again, going all the way back to, it's right there in the name, Partners in Health, this power of accompaniment. It does seem to be it doesn't have to be this way. Why is it this way? Come down to like, what is the one thing that is the most effective, no matter where you are, irregardless of who is doing the accompaniment, right? Yeah. Who can be trusted because of the institutions that are already here. It is this idea, right, that if everyone's going to have equal access, that's got to come from the people around them, right? And that power of accompaniment.
Definitely.
Like you said, but that can also mean organization to organization, right?
Mm-hmm. Yeah, we work with organizations all around. Like, we're not experts in so many things, right? So, and, we're started to do oxygen, and we know how to do oxygen in our facilities. But during COVID, we were asked to help build oxygen plants. Well, we're not going to build an oxygen plant, but we partner with Build Health International, who does our amazing oxygen plants. Mm-hmm. And so together, now we're working in all the places together. So I think it is acknowledging what we're good at, but acknowledging what we're not good at, but also saying what's good when you work in the Miami is not good It may look really different. It's not the same formula that's going to work in Sierra Leone or Haiti. The basic premise is, though, it may look different, but the end of the day, everybody deserves a high quality of healthcare. So just because you live in Haiti doesn't mean that you should get second-rate care, right? It's a long road. We're really trying, but basically it's not less than, when we're really saying, that's why we're still operating all of our hospitals, even now in Haiti. All of our residency programs are still open and running because there's still an entire community to take care of. And that doesn't come from me. That comes from 5,000 Haitians that work for Zami La Sante or PIH in Haiti, because of all of our staff are people from those communities. Like, that's the beauty of it, because they're building capacity for their mother and for themselves and their kids. Like, it's a game changer in that way.
I love you. Thank you for sharing that. It's so instructive and illustrative of, again, there's no one best path forward, but there is a bedrock here that has been proven in so many different places. And the more places it is proven and to be so fundamental and useful and helpful and reassuring to folks, it seems like the more places we can adapt it to. I have some questions I ask everyone, but before I get to those, I do want to talk for a moment about disaster relief a little bit, because I believe you started PIH in Haiti. Was it shortly after the earthquake, right around the earthquake? Wasn't that right when the hospital was opening or something like that?
Shortly after. The hospital opened in 2013, but the major earthquake was 2010. But I started in September of 2010, so after the initial response, but still a lot of the disaster stuff was still operating.
And since then, obviously, there have been hurricanes, there's all kinds of things. And obviously, all these places around the world there's been natural disasters, as we call them, forever. But now we know that in a lot of places, they already are increasing in volatility and frequency. That is something we need to just all talk more about in the, sense of, like, how do we talk about climate change? We talk about it more. That's one of the best things we can do. This, yes, we need to mitigate as much as we can, but adaptation means trying to do a better job of really planning and building infrastructure for this. So I wonder if you can talk a little bit about what you all have learned from that sense that might be applicable as we learn to really try to take these things on in the meantime, especially for so many of these frontline communities who've suffered these forever, who already don't have care or don't have insurance or whatever, home insurance or health insurance. What have you learned that might be transferable for how we best operate going forward?
Yeah, I think when there's disasters, a lot of money appears, and I think, and that's great. Like, you need money when disasters appear. But if you really look at how much money is spent and what gets left behind, disaster relief is the worst way to spend money, right? Because it's not building systems. So we firmly believe that disaster resilience, pandemic preparedness, whatever you want to call it, is best done by having a strong health system. When we look at Ebola, for example, Ebola was in the U.S., did not take off because we have a health system, right? It was able to stop it. It got stopped in Nigeria very, very quickly. It didn't get stopped in West Africa because there was not a functioning basic health system. So we firmly believe that, instead of just throwing money at emergency disaster, use that money to actually make these health systems stronger. That is how we're going to be so much more effective at battling climate issues, pandemics, et cetera. It's so much as how funding is allocated. There's a whole pot of money for disasters, tiny, tiny bit of money for health system strengthening. I think what we're saying is it's all the same thing. And in the U.S., a lot of funding now is under global security, right? It's not under healthcare. There's a lot of reasons that we could go into around that, good or bad. But I think what we're saying is the best global health security is community health workers, right? Who they're the first ones that are going to pick up what's happening around the world, much more so than some extensive drones and surveillance systems. Like, surveillance systems are people. And so, but you can't just plop them in when there's an Ebola outbreak. Like, there has to be that you have people who are trusted in the community. So when people are sick, they know. And it's much cheaper, so much more effective. So how do we shift away from this disaster response to building effective health systems?
Yeah, I mean, again, it seems so frustratingly obvious. I've talked to the folks who are building up, they're called BioBot Analytics, so building up wastewater monitoring in the U.S. Out of Boston. And it just seems so easy. It is so cheap. It
So
just
cheap.
helps. It gives you like a 2-week lead time for at least
Totally.
COVID, which is crazy. If someone had told me 2 years ago, and now they're like, look, we can also do norovirus. Let me tell you what your school doesn't want to deal with, norovirus. Like, can we have a heads up? So I think about those things, and it's frustrating because prevention can go such a long way in that respect in building up these more resilient systems. And I think about what Ed Yong wrote so long ago when COVID first kicked off. And we had two different metaphors, and obviously his is 100 times better, which is, it was I believe it was like the flood that exposed all the cracks that were already in the sidewalk. And mine was like, look, here's the pop quiz. Let's test all of your societal and economical choices to date, and let's see how you did. And the answer is like, not great.
Not great.
But what are we going to fix along those? Because it comes back to like control what you can control and do what you are supposed to do and what you are best suited to do. And, we can start to mitigate for climate, and we can mitigate for pandemics and public health and all these things. But we can also level the playing field. We can have cleaner indoor air. We can have cleaner outdoor air. We can have cleaner water, more water, all these things, because those things will happen. But they don't need to be so bad, and they don't need to happen so often to so many people, especially the people who keep suffering them the most. Like you said, disaster relief, so important, is the sexiest thing.
Yeah, it is. And part of it is, I think, trying to acknowledge that, that is because people feel like they're having impact. They see something and then they're like, I'm giving $5 and I can see what it's going for. It's going to buy water or do whatever. And I think what we need to do is also just shift that. There's suffering that happens all the time. The suffering is horrific. And I think we see it in the media. We bear witness to it in the media when there's an emergency. We don't in the same way. And we don't do exploitive type of media at all. We're always very respectful and about that, but we're suffering every day, everywhere. So I think part of it is, how do we again shift this mindset of, there's a moral imperative for a woman who has breast cancer in Malawi. Like she should get the same care my sister would get. Like that is the fundamental ethos of, and so if you acknowledge that and you absorb that as a human, then you could say, well, to do that, then she needs to have a hospital to go to, and she needs a lab, and she needs chemotherapy. She needs a nurse. So like,
great.
We can start doing that.
Let's do that.
But rather than, I think, just throwing hands up in the air and also saying, oh, there's too much to do. Because there's also a pessimism that gets, the world is horrific and we can't fix what's happening. And, I think we always say that it's only the privileged who can afford to not be optimistic, right? And we can't make that choice for somebody else. And I can't give up on behalf of somebody else, and we're in a place of privilege and we can't do that. And I think that's where it's not turning away, but saying we can do something about it. Like we really can. Yeah. And that's why we're trying to do it in what we touch, but then also beyond. But it really is, a lot of it is, I think, this acknowledgement of each other as human beings. And we are our brother and sister's keeper, regardless of, you'd never see that person.
It's this idea, and it can seem too optimistic at this idea of like problems or opportunities, but there is suffering every day. And so I look to organizations like yours that are doing the side of the mitigation of public health to look and say, yes, but there's people and there's organizations and institutions and models that are working to alleviate that. Again, it doesn't take much to scroll our world and data to see how much better it's gotten. Great.
Exactly.
That was all low-hanging fruit. Let's keep doing those things, and then we'll keep having those issues. We can't control if some hurricane's going to come, much less an earthquake. But we can just keep making the baseline better. And so, again, that is what is so appealing to me about your organization, is the work you do to say, like, no, this works, and it works for the people who've never had any sort of support before. Mm-hmm. So I really appreciate that. I know your time is obviously, and this is like the 5th time we've tried to do this, so I'm not going to abuse it any longer.
But we made it. We made it.
We're not done.
Yes.
Hold on. We're going to get out of here. When I see those files in my folder, we're out of here. Last couple questions I ask everyone, if you don't mind, and then I'll let you run away. The first time in your life, when was the first time in your life when you felt like you had the power of change, the power to move the needle, to do something meaningful? When you kind of took a step back and were like, oh shit, that's interesting. I did something. When was that for you? Because we often find that that's the catalyst, even if folks didn't realize it in the moment, to doing what they do. I
think I grew up in a family that was very focused on justice. And And, the no nukes sign and the like passing or save the seals, like we were always into things like that. And I remember there was an effort. I grew up in rural Maine, right, which was like in the middle of nowhere. Yeah. And so we were a bit of an oddity anyway, this family that had moved from Rhode Island, but where it was boycotting a store that had, I don't even know what they did. They did something, and the store ended up closing, right? Which was a good thing. Mm-hmm. And I remember thinking, wow, like that was because people stood outside and said, don't go here because they treat people poorly. So I think that's like an example of seeing the power of people doing it. I think as a person, I became a nurse because I wanted to help people. I didn't grow up thinking I wanted to be a nurse, but saw that I could get skills and really make someone's life a little easier that day, kind of thing, whether that was from the skill that I had. So I think that was also where, that is fundamentally what I'm trying to do now on a really different scale than what I did then, but still, I think the core of why I'm doing it. And I think that was patterned from my parents and my siblings, who all kind of were in some type of human services. That was just kind of who we are, and was expected, but in a good way.
I love that. Who is someone in your life who has positively impacted your work in the past 6 months?
Oh, that's a good one. 6 months.
Who's been helping to carry you a little bit?
So there's a nurse leader in Haiti. Her name is Mark Chilmise, who's this powerhouse of a woman who I lured away 10 years ago to join PIH. And now she's running our Haiti project. And Haiti's tough, like so much is happening, but she is, and we talk on WhatsApp every day. And I just saw her in Boston, last Friday. And she's somebody who, even in the midst of pure hell, she can, just see the goodness in it and see and just infuse that. Even if this is really tough, you know what, we're going to get to the other side of this. And she's somebody who, it should be the other way around. I should be the one who's rallying her. Right. But I find that she's the one who is just such an amazing leader that is keeping this entire family of 5,000 people in Haiti that we work with going during a really, really rough time. And when I need inspiration, I just check in with her, and she inspires me. That's
awesome. Last one, Sheila, in all of your free time, what is a book you have read in the past year or so that has either changed your mind in some way or opened your mind to maybe a different perspective or idea that you hadn't considered before?
This is probably not what you're looking for, but I love poetry. Poetry awesome. Is what kind of feeds me. So I wasn't new to me, but I hadn't delved into Mary Oliver for many years. She was my mother's favorite poet. And when my mother died, I kind of just put it away kind of sure. thing. And the past year, and even I read, have thought and passed around a bunch of her poems in the past year or so, because it has offered me comfort. I think I spoke at Paul's funeral, and I quoted the Maya Angelou, "When Great Trees Fall," that poem. And so I think it gives me the words that I don't always have as a person to talk about the emotion I'm feeling, or to kind of be that mirror. So I over the past year have started to just read a tremendous amount of poetry and pass it on. I'm sure people are sick of it, but pass it on, because I think it's such a amazing gift. And so that is what the books I read now, other than kind of, workbooks.
Workbooks. Poetry. All I read is workbooks. I mean, I love it, but oh my gosh. But I think, yeah, I don't think people are sick of it. Again, I know you haven't like shoved poetry at me yet. But at the same time, it is such a break from workbooks and these things, but at the same time can be such an end around to influencing how you put those workbooks to use, if that makes any sense. If I can recommend one new book for you, there's a gentleman, a writer named Clint Smith. He wrote an incredible book a couple years ago called How the Word is Passed. But he has a new book of poetry about being a Black man in America and being a parent, and it's called Above Ground. It came out 2 weeks ago, great. Something like that. It is beautiful and wonderful, and
Check it out.
you'll blow through it and fold all the pages over, and it's great. And he's an incredible. He writes for The Atlantic sometimes. I mean, it's just like
that's great.
Such a talented.
Thank you. I love recommendations.
Oh yeah, absolutely. Well, listen, this has been amazing. Where can the people follow you or support PIH? What's the best way to do so directly? Give it to me.
So our website is www.pih.org.
Okay.
And on there is PIH Engage, our chapters in high schools and colleges and communities of how to get engaged with our advocacy efforts around the country, and how to talk to congressmen, how to make a call, how to even write a letter. Like it has a low threshold for kind of engagement. And also on the website, it talks about our work. Obviously, if, people have a skill, if you're somebody who's a critical care nurse who can come for 3 months, to another place in the world, we're always looking for certain skills of like high tech care that, and not a week at a time. We only take people months at a time.
Sure.
I think that's always of interest to us. And then I think just learning about our work and talking about PIH and donating if you're able, any amount is super helpful, is also the way that we kind of keep it going. And I think really just, opening your eyes and bearing witness to what's happening around us, and really making the push for a moral imperative to work with each other is a win for us, even if it's not directly impacting us.
Well, I love that. It seems horribly cliche at this point, but is so instructive because it's so simple, and it speaks to me so much about your work. But I always come back to the find your helpers idea, right? Find the helpers.
Yeah.
And that's you all, and it's incredible. There is suffering every day, but you all have proven this over and over and over again, and it's amazing. So thank you for your work. Thank you for recording with me 5 times at this point. I really appreciate it.
Great, thank you so much. I'll check out the book.
Oh yeah, absolutely. Well, we will talk to you soon. Thank you so much, Sheila.
Yeah. All right. Take care.
All right. That's it. You can read our critically acclaimed newsletter, get up to speed on upcoming podcasts and ones you've already heard, whatever, at importantnotimportant.com. We've also got t-shirts and hoodies and all kinds of things to carry coffee in at our store there. I'm on Twitter and most other places at Quinn Emmett, or at Important Not Imp, or LinkedIn, or what have you. And of course, you can always send us guest ideas, feedback, responses, comments, whatever you've got, at questions@importantnotimportant.com. That's it for this week. Have a great weekend. Enjoy yourselves. Go outside. And thank you, as always, for giving a shit.